Thank you for allowing me to speak this morning. I'll be starting off with an overview of the reasons that cardiac causes of stroke are important in young adults, and then we'll discuss specific entities in some detail. So just as a review, ischemic strokes represent 85% of all strokes, and cardiogenic embolism makes up approximately 20% of that 85%. Cardioembolic strokes have been associated with a worse prognosis compared to other stroke subtypes, as well as a larger infarct size. This may be due to larger sized thromboemboli, as well as the abrupt onset of vascular occlusion, which may be even more catastrophic in cases where collateral blood flow has not developed. In addition, cardioembolic strokes have been associated with hemorrhagic transformation more so than other stroke subtypes. This is data taken from a paper published in Stroke in 2000 by Petty and colleagues, and it just highlights the fact that cardioembolic strokes have worse outcomes. So specifically in patients 1 year after stroke, where a good outcome was defined as a Rankin score of 1 or 2, only 27% of patients with cardioembolic strokes achieved such a Rankin, compared to 82% with a lacunar etiology, 53% with large vessel atherosclerosis, and compared to 50% with cryptogenic strokes. In addition, cardioembolic strokes have a higher case fatality rate. Data from the same paper published by Petty and colleagues looking at the 5-year mark. These are probabilities of death. Cardioembolic strokes associated with an 80% risk of death at 5 years, compared to 32% again in large vessel athero, 35% with lacunar strokes, and 49% with cryptogenic strokes. This is a picture highlighting some of the common cardiac reasons for strokes to occur. A points out a paradoxical embolism, whereby there's a communication between the right and left sides of the heart. B, a pulmonary vein thrombus. C, a left atrial thrombus or a left atrial myxoma. D, mitral valve annulus disease. E, shows a left ventricular thrombus. And then finally, F, aortic valve disease. So we'll start off by talking just briefly about secondary prevention. Again, broadly speaking, Afib is treated with either warfarin or one of the novel agents. We're not going to talk in a lot of detail about those in particular with this talk, as we're speaking mainly on young folks today. And then we'll also discuss treatment strategies for other cardioembolic sources of stroke. But to touch on Afib briefly, it is the most common arrhythmia that's present in 4% of the population above the age of 60 and in 10% over 80 years of age. It is one of the strongest independent risk factors for stroke. It increases stroke risk fivefold. That's 5% per year for the first stroke and 12% for the second stroke if untreated. Afib strokes are also twice as likely to be fatal. We wonder whether that's associated with just the fact that they're more prevalent with increasing age. What about Afib and stroke prevention? There are trials for both primary and secondary prevention. The trials demonstrate a 67% relative risk reduction with warfarin as compared to placebo. That risk is about 20% with aspirin compared to placebo, so quite a bit of difference. In patients with thyrotoxicosis, about 10 to 30% of these patients get a fib, and 2 to 5% of all patients with thyrotoxicosis, of all AFib patients have this condition. The holiday heart syndrome, which you may have heard of, can be associated with alcohol use, and heavy salt intake can have an Afib association. And then finally, there's the concept of lone Afib, which is in patients that are asymptomatic, less than 60 years of age, and have few cardiac risk factors. These are generally treated with just antiplatelet therapy. There are ways to stratify risk with Afib. High-risk patients are those that have had a stroke or a TIA in the past, systolic blood pressure is above 160, heart failure, women over the age of 75. Moderate risk patients are those that have a history of hypertension, but none of the other risk factors mentioned. And then finally, low risk patients are those without any of the above risk factors. And there are scores that you've probably heard of, things like the CHADS-VASc score, to help quantify the risk of stroke moving forward in a patient with AFib. So the recommendations, so generally speaking, patients that are in that high-risk category should receive warfarin or a novel anticoagulant. Moderate risk patients depends on the patient preference, bleeding risks, et cetera. And then finally, most low-risk patients just are treated with aspirin. So just a few words on AFib. We'll move on to other cardioembolic sources. Spontaneous echo contrast, which is sometimes called smoke. Acute MI. We'll spend some time talking about PFOs as well as other causes. Spontaneous echo contrast is seen on TEEs often in the left atrium and found in patients that have AFib and mitral valve disease. It's a probable marker of a low flow state, and it may represent microaggregates of platelets or erythrocytes. It's present in up to 19% of the general population and in 74% of folks with AFib or mitral stenosis. This is a video of an echo, which I hope works. So I'll play that again. You'll see some wispy material that I'm highlighting with my mouse right now. That is the so-called smoke in the ventricular chamber. This is a little bit of a better picture of that. There again is the wispy smoke-like material thought to indicate a low... I'm sorry? Oh, I apologize. We do, so kind of that area. So that right there. So what about smoke and the risk of stroke? The SPAF3 trial showed that smoke is an independent risk factor for stroke, a relative risk of 3.7 in a cross-sectional analysis. They also performed a prospective trial in AFib patients, and what they found was that patients with smoke had an 18.2% per year stroke rate, quite high, 2.9-fold higher than those without smoke, in a total of 382 patients. It's also been associated, smoke has, with increased stroke mortality by O'Brien and colleagues. Having said that, though, there's not convincing data based on other studies. Several other authors have found no correlation in a study of 409 patients with non-valvular AFib. There was no correlation between smoke and recurrent stroke. Finally, in the TOAST trial, they found a 14% annual risk of stroke versus a 4% risk in those that did not have smoke on their echoes. Moving on to sick sinus syndrome, limited data on this particular topic, only a couple of studies, one published by Rubenstein, who reported on 56 patients, of which 10 had a stroke, that's 18%. Fairfax and colleagues reported on 100 patients, of which 16% had a stroke versus 2% with complete heart block. Those with a pacemaker in sick sinus syndrome, the recurrence rate was 2.2% at 1 year and 5.8% at 4 years. How about acute MI? The risk of stroke appears to be relatively high, especially in the first 3 months, 2 to 5% after an acute MI for a stroke. That risk is highest in the first week, and there are some factors that have been associated with a higher risk of stroke moving forward after an MI. Anterior wall MIs, advanced age, poor left ventricular function or congestive heart failure, a history of prior MI, as well as a stroke or embolic event. In unselected patients, there appears to be a marginal benefit to using warfarin. And in those with higher risk, warfarin is sometimes used and probably should be with an IR goal of 2 to 3 for about 3 months. Long-term use is generally not recommended unless a thrombus is visualized on an echocardiogram. More data on warfarin and acute MI. Herlin and colleagues published a study in 2002 of over 3,000 patients that were randomized to aspirin versus high-intensity warfarin versus intermediate-intensity warfarin after an acute MI. They were followed for 4 years, and they found a decreased stroke rate as well as a non-fatal MI rate in both warfarin groups. It's a little bit surprising. We often don't see these people after an acute MI, but they probably should be getting warfarin for at least a short time. So clinical factors are one thing. You can also actually look at left ventricular dysfunction in AFib patients, and that can tell us something about the rate of stroke risk going forward. This is data that's combined from 3 separate studies, the SPAF1 trial, the SPINAF trial, as well as the BATAF trial. And what it shows is that on the x-axis, with increasing left ventricular dysfunction, the stroke rate also increases. This is independent of age, hypertension, diabetes, prior stroke, as well as heart failure. The WARSIF trial is an important study. It looked at patients with ejection fractions of 35% or less, and it randomized them to adjusted dose warfarin versus aspirin and looking at recurrent stroke rates. They were followed for more than 2 years, and over 2,300 patients were enrolled in the study. What they found in the primary outcome, which was ischemic stroke, ICH, or death, that there were no differences between the aspirin and warfarin groups. There's a but. But when you look at ischemic stroke specifically, there were lower rates in the warfarin group. That was offset, however, by higher major bleeding rates with warfarin. So my practice, and from what I've seen from a lot of my colleagues and in my training, has been to generally not anticoagulate these folks that have low ejection fractions without any other reason for anticoagulation. Switch gears a bit and talk about PFOs. PFOs are common, as we've already heard in prior talks today, present in up to 1/3 or even more of individuals. Generally more common in women as compared to men, more common to see smaller PFOs as compared to larger ones. And as per at least one autopsy study, they appear to decrease with increasing age. So in one particular study, PFOs were seen in 20% of folks in the 9th and 10th decades as compared to 34% in the first 3 decades. Another video, which I'll play. Where's my pointer? So this cavity right here is the right atrium and the right ventricle. I'll play the video again, and what you'll notice is that some amount of this contrast going across the interatrial septum. I'll play that again. And it's actually even more obvious on the next video. So this is the right atrium, the right ventricle. The orientation is a little bit off here, but what you'll see, and I'll play the video one more time, is that there's quite a bit of the contrast agent going across a large interatrial septum. So what about genetics and PFOs? There has been a link to a defect in the TMX2 transcription factor gene. It's associated with both ASDs and VSDs. The inherited tendency for PFO in sibling pairs, however, has only been shown to be present for women only. So specifically an odds ratio of nearly 10 if you're a woman and you have a sibling with a stroke and a PFO. That odds ratio was not increased in men. So that genetic tendency has been shown only in women with stroke and PFO. This is an interesting study that's a bit old, about 10 years old now, but it looked at treatment strategies between neurologists and cardiologists in terms of how they deal with PFOs. This is before the three major PFO trials were published, but I think still somewhat intriguing is that neurologists are more likely to prescribe, or at least they were, antiplatelet agents and warfarin as compared to cardiologists, and cardiologists were more likely to prescribe, or recommend, I should say, endovascular closure as compared to neurologists. This may have changed, of course, with our three big trials that we'll discuss in just a few moments. What about PFO and other neurologic diseases? PFOs appear to be more prevalent in decompression sickness. 61% of sick divers have PFOs, and migraineurs, as we heard in our first talk, have an increased PFO prevalence. The MIST-2 clinical trial was a trial that was looking at randomizing patients to PFO closure versus medical therapy to help migraines. The trial was actually stopped early because of slow enrollment. The company sponsoring the trial wanted to put their efforts into actually studying stroke recurrence as opposed to migraines. And what about this risk of stroke from PFOs? A controversial topic. Lechat and colleagues found that PFO prevalence was increased in stroke patients, so specifically in patients that are less than 55 years of age. The PFO prevalence was 40% compared to 10, quite dramatic. And that's even higher in cryptogenic stroke patients, 54%. That's using a contrasted TTE. Similar results were seen with a contrasted TEE, so in patients that were less than 40 years of age that had a stroke, PFOs were seen in 50% as compared to 22% in a control group. Renaud and colleagues questioned whether PFOs are really significant. Again, as we just heard in our last talk, if you have a PFO, the clot's got to come from somewhere, and what they demonstrated was actually no DVT being present by venography in those patients that had strokes with PFOs. Stone and colleagues found that large shunts appear to increase the risk of recurrent stroke. A small study of 34 patients, 31% of patients with large shunts had a recurrent TIA or stroke compared to none in a small shunt group after a 20-month period. Atrial septal aneurysms, these can sometimes be associated with PFOs. They're highlighted in red on the slide. The far left is a normal picture. The middle shows an atrial septal aneurysm in early systole, and the far right shows what it looks like in late systole or diastole. So if we keep our eyes on this part, I'll play that again. You'll see a large kind of flapping atrial septal aneurysm on the echocardiogram. What about the risk of stroke in patients with atrial septal aneurysms? There appears to be an increased risk of stroke in patients that have a PFO and one of the following, either migraines, a PCA infarction, or another cause of stroke. In this particular study of 140 patients, there was no increased risk with atrial septal aneurysms or varying treatment modalities. Again, 140 patients with stroke and PFO. The recurrent stroke rate was quite low, not even 2%, and the mean follow-up was 3 years. So hard to draw conclusions based on the fact that these are such low numbers. And then moving on, Moss and colleagues found that there is an association of PFO with atrial septal aneurysm and that it may increase risk of stroke. So in this particular study, 531 patients, so 216 that only had a PFO. The risk of recurrent stroke there was a little over 2%. In those with both PFOs and an atrial septal aneurysm, that risk jumped to 15.2%. And then at the very bottom, 304 with no atrial septal abnormalities, the risk was 4.2%. So to summarize atrial septal aneurysms, there is conflicting data, and that's kind of where things stand. Treatment options for PFOs, broadly speaking, aspirin, warfarin, umbrella closure via catheter, or surgical thoracotomy. As far as medical treatments go, Orgura and colleagues in a meta-analysis found that warfarin was superior to antiplatelet therapy in 2001 with an odds ratio of 0.37. They also found that surgical treatment was similar to warfarin with an odds ratio of 1.19, but the treatments in this particular trial may have varied by the severity of the lesion, affecting some of the interpretation. What about primary prevention? In a no-mass cohort study of 1,100 patients with no stroke history, the PFO prevalence was about 15%, and at 11-year follow-up with nearly everyone following up with an outcome of first ischemic stroke or silent brain infarctions, the hazard ratio for ischemic stroke in PFO patients was 0.97. There was a trend towards a higher hazard ratio in patients that were less than 60. And then silent brain infarctions, the odds ratio there was 1.15. Additional medical treatments for PFO. So there was a subset of the WARS study published by Homa and colleagues, a total of 630 patients with non-cardioembolic strokes. PFOs were present in 34% of these patients. They found no difference between a PFO being present versus not present in terms of the stroke rates, 14.8% to 15.4%. There was no difference based on the size of the PFO, no difference with an atrial septal aneurysm, no difference between whether the patients got warfarin or aspirin. And then moving on, a meta-analysis of observational studies published in 2012 looked at all recurrent neurologic events per 100 patient years. And this observational data suggests that that transcatheter closure of a PFO is helpful. The relative risk is 5.0 for a recurrent event in the medical arm compared to 0.8% in the procedure arm. But I want to caution, this is observational data, and we do have randomized trials that have since been published. That brings us to the aforementioned trials. 3 recently completed trials. The punchline is that none have found a significant difference between medical management and percutaneous closure. We'll talk about them in a little bit of detail. One is the Closure 1 trial. It's a 1-to-1 randomized study. It evaluates patients with initial stroke or TIA that also have a PFO. They compare the incidence of recurrent stroke or TIA in patients undergoing closure of the PFO versus best medical therapy. Patients were enrolled 18 to 60. They had to have a clinical diagnosis of a stroke or a TIA, and then a PFO with no other source of embolus. This is the device they use. It's called the Starflex. And just a brief aside, this is a case study of a patient that had one of these Starflex devices put in to close the PFO. It's a gentleman that had a stroke at age 54 in the year 2000. His PFO was closed in 2003, and 5 years later he developed a thrombus on his device, which you can actually, I'll point out right there. And it was removed after 6 months of intensive anticoagulation, and that's what it looks like. That's the large thrombus on his device. So these are not without risk. Doing any procedure, it's always important to keep that in mind, that it's not just that we're closing it and that's the end of the story. They do have some risk associated with them. So the results of Closure 1, a total of 909 patients. In the primary endpoint of the study, 5.5% of patients reached that endpoint in the closure group versus 6.8% in the medical therapy group. That was a non-significant difference between the two arms. This is taken from the paper directly, again, showing on the y-axis the probability of the primary endpoint, and then the x-axis days since baseline. And when you zoom in, you see that the curves do diverge a bit with medical therapy on top versus closure on the bottom. But again, these are non-significant differences. What about subgroup analyses? Do particular patients benefit more than others based on subgroups? The answer, as per Closure, was no. Pre-specified subgroups included gender, atrial septal aneurysm, shunt size, whether you had a stroke or a TIA to get into the study, or baseline medications, and none of these subgroups demonstrated any statistical significance. What about safety? Afib was more frequent in the closure group, 23% of patients versus 3% that didn't have their PFOs closed. Afib within 30 days after the procedure was present in 61% of patients that had their PFOs closed, transient in 17, and persistent in 6 of those patients. The next trial to investigate this question was called the PC trial, and it enrolled 414 patients with 4-year follow-up. The primary endpoint was achieved in 3.4% of patients in the closure group versus 5.2% in the medical therapy group. Again, that is a non-significant difference between the arms. Non-fatal stroke also showed no difference, as well as TIAs. And then lastly, the largest of the 3 trials, RESPECT, enrolled 980 patients with a mean age of 46, and the medical therapy group received 1 or more antiplatelet medications or warfarin. It's notable that there was a higher dropout rate in the medical arm. And the primary endpoint in the intention to treat analysis, these are relatively low numbers, 9 events in the closure group versus 16 in the medical therapy group. That was a non-significant hazard ratio of 0.49. Looking at recurrent stroke specifically in the patients in the per protocol analysis, there were only 6 events in the closure group versus 14 in the medical arm. That was significant. And then lastly, looking at recurrent stroke in the patients in the as treated analysis, there were 5 events with closure and 16 for medical therapy. That was significant as well. Pre-specified subgroups, again, similar to what we talked about earlier in closure 1, gender, shunt size, atrial septal aneurysm as some examples. And what the authors found was that a substantial shunt size and the presence of an atrial septal aneurysm, those 2 subgroups demonstrated benefit for closure as compared to medical therapy. What about safety? There were less peri-procedural AFib events than in the closure trial, and procedural right atrial thrombus formation and PEs was increased, however, in the group getting their PFOs closed. So to summarize these 3 trials, closure, PC, and RESPECT, follow-up was at 2, 4, and 2 years respectively. The primary endpoints are listed. High technical success rates. None of them demonstrated significance statistically between PFO closure versus medical therapy. And the latter 2 trials used the Platzer device as compared to the Starflex, which we looked at in the closure study. There is another trial called REDUCE. That's a prospective randomized open label trial that compares closure with a different device that's called the Gore Helix Septal Occluder. That's being compared with antiplatelet therapy in patients with PFO and ischemic stroke or TIA. The primary outcome being recurrent ischemic stroke or TIA, and we hope to receive results within the next couple of years. This is a slide just demonstrating what bubbles look like in a TCD bubble study. So before injection in the top left corner, without a Valsalva maneuver, all these it's relatively easy to see the vertical lines, and the bright signal indicates bubbles going across and entering into the brain. Besides the visual output that you see, there's also a very noticeable audio signal that's hard to miss. And there's actually some evidence that indicates that the shunt grade may be related to your risk of stroke going forward. So specifically, the dark bar represents patients that have a high shunt grade, a TCD shunt grade of 3 or more. And those folks had a lower survival-free period of strokes and TIAs going forward as compared to those with a lower shunt grade. So to summarize PFOs, they're common. They may be increased in the stroke population, particularly in younger patients. Bigger shunts and associated atrial septal aneurysms may increase stroke risk. That's still controversial. And the best treatment has been studied. That also is controversial. I generally will give these patients just aspirin unless there is another indication for anticoagulation. If they're having recurrent events with a cryptogenic etiology and a large shunt, I may point to those subgroups from respect as a justification to close the PFO, but I would say broadly speaking, generally, antiplatelet therapy. What about other cardioembolic etiologies? Atrial myxomas are rare, but they have a high embolism rate of 40%. The treatment for that is surgical excision. These are benign intracardiac tumors. Mechanical valves generally warrant anticoagulation with an INR of 2.5 to 3.5. Bioprosthetic valves typically are treated with just aspirin, and mitral valve prolapse is not associated with an increased stroke risk unless it is complicated. Mitral valve prolapse, often a presenting complaint is palpitations. Patients may feel chest discomfort, but it's dissimilar to angina. Dyspnea and fatigue may be present, anxiety and panic attacks. There's a characteristic mid-systolic high-pitched click. It's usually followed by a medium-pitched murmur. Overall, 3.5% of patients with mitral valve prolapse get infective endocarditis. That's a 3 to 8 times increased risk. And with severe MR, that jumps to 12%. Mitral valve prolapse in the presence of a patient having a stroke or a TIA without AFib, generally those folks are treated with just antiplatelet therapy. All these patients should have antibiotic prophylaxis to reduce the risk of developing endocarditis. This is what mitral valve prolapse may look like on an echocardiogram. So the dotted line represents where the mitral valve should be, and it's prolapsed into the left ventricular cavity. Cardiologists generally will not follow asymptomatic mitral valve prolapse without regurg. If there is mild to moderate regurgitation, then they'll be followed every 1 to 3 years, and if moderate to severe, every 1 year. Moving on to atrial myxomas, these are benign intracardiac tumors. They're relatively rare. They often present, however, with congestive heart failure or embolism, less commonly with tachyarrhythmias. So that is the myxoma. I'll play that again. This is a gross pathologic specimen of a atrial myxoma. TTEs are about 50% sensitive, whereas TEEs are 100% sensitive. 92% are left atrial, and the remaining are either biatrial or right only. These are rarely familial, but when they are, the recurrence rate appears to be higher. Surgery is generally curative, and these myxomas may be a risk factor for infection down the road or even a subsequent aneurysm. Infective endocarditis, there's a high risk of stroke with IE, 15 to 20%. The majority of the events happen within 48 hours of the diagnosis, and much fewer happen after that time period. Anticoagulation is generally contraindicated because of the high rate of hemorrhage. Mycotic aneurysms, the rupture is unpredictable. Usually just treat these folks with antibiotics, and most are not treated surgically. So let me see here again. So that is a vegetation on a heart valve. This is an angiogram demonstrating a an infective aneurysm in a distal branch. What about valvular strands? These are highly mobile, filamentous, linear, and echogenic material. They're 2 to 10 millimeters in length and 1 to 2 millimeters thickness. They appear to be more common with increasing age, and they are the equivalent to Lamboll's excrescences. They're most commonly present on the mitral valve. And what about the risk for stroke? It's unclear if these are if there's a causal relationship or if it's just a disease marker. Pearson and colleagues showed increased strands in stroke patients, 5% in stroke patients on TEEs as compared to 0.3% in non-stroke patient TEEs. Roldan and colleagues showed no increased risk of future stroke in healthy volunteers, 1.4% of which had strands in a stroke and then 2% without. And then finally, Cohen and colleagues found more strands in stroke patients, but not an increased risk of future stroke going forward. So unclear if it's just a marker of disease or if there's a causal relationship. What about valvular calcifications? Mitral annular calcifications are common in elderly folks. In the Framingham study, they reported double the stroke risk with increasing severity, but carotid disease was not considered in that particular study. Ferlin and colleagues showed a small stroke risk, indicating it's probably just a disease marker, these calcifications. 63 total patients that were followed for over 3 years. 22% of those that died had over 5 millimeters of these valvular calcifications. 2 patients with TIAs, 3 with strokes, and none appeared to be of embolic etiology. These may be, however, a nidus for thrombus formation. These are axial CAT scan images. The left demonstrates a calcified embolus that appears to be present in the proximal branch of the right middle cerebral artery, and after the patient got TPA, it moved distally into an M2 branch. So to summarize treatment, warfarin is used for patients that have Afib or a novel agent for Afib, except in the cases of lone Afib. In acute MI, except in patients that have inferior wall MIs, they should get about 3 months of warfarin. And then patients that have mitral regurg with Afib should get warfarin. And then lastly, non-bacterial endocarditis also warrants anticoagulation. We're not sure in terms of what to do with mobile mitral valve strands or in rheumatic mitral valve disease without Afib. All others should get antiplatelet agents, and then again, antibiotics should be administered to patients with mitral valve prolapse who are having a procedure performed. That is my last slide. I'd be happy to take any questions at this time.
One question. The study that you show, I think the Warsef study, on heart failure patients with an EF less than or less than 35%, that showed that Coumadin versus antiplatelet therapy was the similar results or outcomes. I believe there was for primary stroke prevention. What about patients, either young patients or elderly patients with an otherwise cryptogenic or maybe radiographic signs of possible cardiogenic stroke, not on AFib, but otherwise the ejection fraction is 30%, 25%. Do you think that those results apply to those patients?
I think that they do apply. I generally use antiplatelet therapy even in those cases. If their ejection fractions are that low, then I think it's important to look hard for AFib. I'd be in favor of 30-day event monitoring, even loop recorder monitoring, because of their low EF. They're at increased risk for developing AFib, but generally antiplatelet therapy.
Hi. Thank you for the presentation. It was great. What is your favorite first-line treatment for infective aneurysms in infective endocarditis, if they are non-ruptured or ruptured?
In terms of blood thinners, or?
In terms of treatment.
Treatment.
Actually, would you just do antibiotics, or you would do an intervention? Would you coil them? Would you clip them? For aneurysms.
Yeah, so the treatment should be just antibiotics in most cases.
Even if they are ruptured. And
If they're ruptured, that's a different issue. If they're ruptured, I would ask for some vascular neurosurgery assistance, but in the absence of rupture, antibiotics. Yeah.
yeah, thank you.
Okay, thank you.